is a senior professor at where I am at University College London. I've known him for many years, and I know that we're in for a treat. Perry, thank you.
Thanks very much, Derek, for that kind introduction. Great pleasure to be here. Now, how can I possibly follow that introduction? You need to know something about me, I think, first of all. I'm what's called a cardiomyopathy doctor, which is a very strange breed. Okay, we don't have all the friends that Mark has. Mark represents a pedigree of trials, thousands of patients. You have friends wherever you go. You walk into a bar, there are heart failure doctors everywhere. Whereas I'm the lonely guy on the edge of a party trying to find someone who thinks the way that I do about these strange heart muscle diseases, genetics. We meet quietly on mountainsides at midnight, dance around trees naked. It can be fun, but it is still quite lonely. And Derek's given me the job here of talking about sudden cardiac death because I think of my focus on sudden death amongst these rare diseases. And that's what I'm going to talk about. But I'm going to talk about it as an evangelist because I think from rare and uncommon disease is emerging one of the frontiers in pushing medicine forwards. Mark said, it's no point of being a doctor unless you're going to change things. We only change things if you think outside the box. But sudden cardiac death, actually, all of the speakers over the next day and a bit are going to be talking about sudden cardiac death. Why? Because it's really common. 15 to 20% of the population dies suddenly. Now, of course, that excites cardiologists, because we love a challenge. We are going to defeat this. We're the guys who understand what makes the heart stop. We have lots of really sexy things to prevent sudden cardiac death. This is our mission. And we've invested a huge amount of time, effort, money, and understanding the things that cause sudden death, the substrates for sudden death, the triggers for sudden death. But if you look at this as a public health doctor, it's all about coronary disease. And therefore, it shouldn't come as a surprise that whilst we talk about this epidemic of sudden cardiac death, actually, if you look at the prevalence of ventricular fibrillation in the general community, it's declining. And why is it declining? Is it declining because of putting in defibrillators in everybody? No. It's declining because of primary prevention. Sudden cardiac death risk here, following discontinuation of smoking. Something else that's happening, which has got nothing to do with the defibrillator, is the fact that if you do have VF arrest, you're much more likely to survive to hospital. And this is a Danish study, and you can see here the biggest rise is in patients who've had bystander CPR. Now, is that because of better trained crews? It might be, but look here what's been happening during this period. Training kids to do resuscitation. In Denmark, you have to have resuscitation training to get a driver's license. Improving survivability is about public health policy. Another hard truth, if you focus on death, is that, if you've got a shockable rhythm when the ambulance crew get there, your survival rate's increasing. If you've got a non-shockable rhythm, first of all, the incidence of that hasn't changed in 20 to 30 years. And the second thing that hasn't changed is survivability. Are we really surprised by that? If you look at the demographics of people who have pulseless electrical activity or asystole, when the crew arrives, they're older, they're more likely to be female. Many of them have no history of prior cardiac disease, and of course they have comorbidities. We are a mortal species. We do die. So there is an irreducible number of deaths, which even we, as cardiologists, with all of the tools that we have, are very unlikely to eliminate. So, to anchor this part of the talk, if you're talking about sudden cardiac death as a public health issue, I think it's about this, which is why actually all the subsequent speakers over the next day or so are going to be talking about prevention of sudden death, because it's about primary prevention. And this one, it's about healthy aging. But I'm not going to talk about that, because I'm a cardiomyopathy doctor on the mountain. And if I come back to this list of sudden death causes, I sort of occupy this space up here. All the scary stuff. You know, the stuff that you read about in newspapers, in magazines, regularly in the journals, the killer diseases, whether they be electrical, whether they be structural diseases, the prevalence of which varies according to which population you look at. And why do they excite so much attention? Well, the first reason is because they tend to affect younger patients. So if you're looking at electrical disturbance or cardiomyopathies, the deaths that occur are not that common, but they affect the young. Although I'm going to come back to this one, non-ischemic dilated cardiomyopathy, that's not just a disease of the young. But the other reason it attracts attention, and the other reason that it shapes our thinking about treatment and also about interpretation of data, is because it often happens in prime time. So that's why we focus on these diseases and sudden death risk. Now what I'm going to do is I'm going to pick two diseases to compare and contrast them, to show how our thought processes are conditioned. They're conditioned by the story of a disease, where a disease has come from, more by perception than data. So this one, hypertrophic cardiomyopathy. So this is the killer, right? You know, patients who get a diagnosis, they go home, they have what I call a Google moment. You put in hypertrophic cardiomyopathy and you know you're going to be dead by the end of the week. It's a very powerful substrate for death. Hypertrophy, disarray, ischemia, fibrosis. But you know what? Sudden death doesn't happen very often in this disease. If you look at the trends in, these are largely sort of tertiary referral populations over the past 10, 20, 30, 40 years, you know, changing demographic, but the rate of ventricular arrhythmias, including ICD shocks, is way less than 1% per year. It's about 0.6% per year in contemporary studies. So for most people with this disease, it isn't the killer that you read about. And of course, that's the challenge, because you're talking about rare events, and how do you predict rare events? Now, this is someone who is likely to be at risk. This is a 65-year-old guy. It's the only example I have of ventricular fibrillation in a patient with hypertrophic cardiomyopathy having an exercise test. He did this. We resuscitated him. It took me 5 days to persuade him he needed a defibrillator. And this was about 15 years ago. The device has never gone off again. But even I, as a crazy Brit, would never say, don't put a defibrillator in that kind of patient. But of course, most people don't survive that event. And so what we're trying to do is to anticipate that. And the way we've done it in hypertrophic cardiomyopathy is to look for features of the disease that associate with risk. And from that list, this is far from an exhaustive list. From that list, we've picked those factors that we believe to be most predictive. So family history, unexplained syncope, blood pressure response, VT on a Holter, severity of thickening of the ventricle. And for about 15 years, we took a very simplistic approach to risk, and we said the more of those things you have, then the higher is your risk, and then we'll have an argument about what the threshold is for putting in a defibrillator. Now, can I say there's nothing magical about this? It's just telling you how bad your heart is. But does it work? Does it actually discriminate between the high and the low risk patient? And it took us a very long time to really test that. And if you do test it, this is looking at the ability of this 1, 2, 3, 4 risk factor model to discriminate between a high and a low risk patient. ROC curve, if it's a random test, it should be a straight line. Well, it's not a straight line, but it's not that great. So how do we improve on that situation? Well, I think it's not unfair to say that in medicine we do one of two things if we're faced with a problem like this. The first is that we do that. There's a problem with the data. Let's just do the study again, and we know we'll get the right result. I think that's the definition of madness. Another thing that we do all the time is we say, yeah, but I've got a new test. And I know that that test is really good, and that's going to solve the problem. So in hypertrophic cardiomyopathy, this is the current one. And it's a great test. You can see one of the substrates for sudden death, fibrosis, using cardiac MRI. But is it the magical test that tells us everything? You're dealing with complex biology here. We'd have to be really lucky to have a test that told us everything. Whether that's an ejection fraction, or MRI, or VT, or BNP, biology doesn't work that way. And we've known that for a very long time. You have to have a multi-parametric approach to describing disease, and that's essentially the models that we use in all the various risk scores that we apply in clinical medicine every day. And so, a while back now, we said, well, can we do that in a less common disorder such as hypertrophic cardiomyopathy? Nothing revolutionary, except for the fact we were studying thousands of patients rather than hundreds of patients. Went to the literature and said, what are those things that seem to associate with risk, age, family history, blackouts? Nothing particularly strange here. Age, really important though. And you put them into a model, and you get a model which increases the area under the curve to a performance similar to that of CHA2DS2-VASc. And then we incorporated that into a tool to estimate risk. Now this tool is a way of discussing risk with the patient. It's a way of putting a number rather than a belief system on what is going to happen according to their clinical phenotype. What you do with that information, of course, is a different matter. And this is the way in which we think in clinical medicine. We love thresholds. And this was what we put into the ESC guideline for what you do with that information. As I pass, and this is more a thought for when you're sitting in the bath this evening, where do these numbers come from? 6%, put a defib in. Less than 4%, don't put one in. Did Moses come from the mountain, and on the 11th tablet it said, thou shalt put an ICD in when it is more than 6%? No. This is 21 people sitting around a table saying, what do you think? 6%? Ooh, 8%? Ooh, 4%? We don't think about risk in absolute terms in medicine, because there is no such definition as acceptable risk. Anyway, moving on. The study's rolled out, further validation. If it's got a flaw, is that it's too aggressive. We tend to over-predict the risk, again, illustrating the fact that most people with hypertrophic cardiomyopathy, even those that we deem to be at high risk, don't have an event. So actually what we end up doing is putting in more ICDs than we need to. But I want to show you this slide because by doing things to patients, we change the natural history. We rarely cure things in cardiology or indeed in medicine. We change the trajectory. And in hypertrophic cardiomyopathy, we've forgotten the fact that hypertrophic cardiomyopathy is heart failure. It just takes you 10, 20, 30 years to get all the bad stuff. And so if you look at what happens, this is from a North American registry, the SHARE registry. If you wait long enough, patients get heart failure, they get atrial fibrillation. So if you're looking for an opportunity in therapeutics in hypertrophic cardiomyopathy, it's not about putting defibrillators in. It's about coming up with drugs or interventions that modify the long-term natural history and prevent progressive ventricular dysfunction. Now, what about this one? Dilated cardiomyopathy. poor old dilated cardiomyopathy. The D stands for dull. Big baggy ventricle, not really interested in that. There's nothing coronary about it. We can argue about what it is, ejection fraction less than 50%, more than 50%. You know, remember, this is who I am. This is our last working group meeting. Dilated cardiomyopathy is a genetic disorder. If you genetically test people with dilated cardiomyopathy, 1 in 4 of them will have a definite or pathogenic mutation. This is from a large European study. This is from another North European study. If you have a family history, you'll find a mutation in 50%. This is a genetic disease. Oh dear. Really? Does that matter? Because, you know, we know that if you organize heart failure according to an ejection fraction and you have the massive evidence of trial data that we can manage heart failure, drugs, devices, CRT, defibrillators, and even in that curious dilated cardiomyopathy world, all of that stuff has impact. So if you look at survival from the 70s, 80s, 90s, thousands, heart transplantation, heart failure, sudden death, all improved. Why? Because we were using beta blockers, ACE inhibitors, spironolactone. For that small group with whom we put in defibrillators, yeah, we got really good evidence to show that defibrillators also work in that group. And all of that translates into guidelines. Class 1, thou shalt put an ICD in if you're still symptomatic and you've got ejection fraction less than 35%. Yeah, really, really don't worry about the genetics. Okay. Do defibrillators really protect people with DCM? Danish trial, it shows that they don't. They do reduce sudden death rates, but of course the natural history of the disease progresses, and they die from other things. Ah, yes, but yeah, subgroup analysis shows that if you're less than 65, then you benefit. And I didn't think we were supposed to do subgroup analysis. Inconvenient facts. Let me just show you a couple of things. 49-year-old guy, breathless, he's a chef, he drinks too much, he's got ejection fraction of 35%, someone does an MRI, he's got a bit of scar, he's quite twitchy. This is his MRI, it's horrible. So what do we say? Okay, put you on drugs, we'll see you again in 3 months' time. If you're still symptomatic, you might need a defibrillator. So stop drinking, take away the major risk factor that you have. A 71-year-old guy. A little bit unusual this time, but he's been referred to the clinic because some crazy cardiomyopathy doctor has said, look, you've lost your nephew, he's dropped dead suddenly with DCM, you better go and get checked out. But hang on a minute, I'm fine, I'm playing tennis 3 times a week. He has some tests, ejection fraction is 45%, someone puts him on ramipril, he's got a little bit of twitchiness, but is that so bad for a 75-year-old or 71-year-old? A 24-year-old guy. Now, this is a tricky one, but his father died suddenly in his 40s. There's some story about mitral valve disease and that kind of stuff. He's diagnosed with ARVC, antiarrhythmics. He's got 34% burden of ventricular ectopy. He's got 11% burden of supraventricular ectopy. He's probably got tachycardiomyopathy. He has people repeatedly set fire to his heart trying to get rid of the ectopy. His heart is horrible. He feels fine. Leave me alone. So what have I shown you here? Case 1, dilated cardiomyopathy, practice according to guidelines. Pretty straightforward. Case 2, he's now got what we call in Europe HEFMREF. No evidence-based therapy, treat empirically maybe. This is the 71-year-old with the family history, ejection fraction 45%. In case 3, this is a really tough one. What do we do with this one? More ablations, more drugs, ICD, transplant. Now, case 1, So he's put on therapy, come back and see us in 3 months' time. He goes to Paris to have a good time and has a cardiac arrest in the street. He's resuscitated, has an ICD. Now, if I said he had scar, if I get this to work. So, scar, we get obsessed by how much scar. The scar's in the back wall here. What's it telling us? Why is there scar? Why is there a scar in this guy? Subepicardial scar. So you've got a phenotype, which is dilated cardiomyopathy, ventricular ectopy, posterior wall scar with a father that dropped. No, wrong guy. He didn't have a family history. What is the diagnosis? It is not DCM. He has a desmoglein mutation, a desmosomal mutation that kills you. So the guideline, the paradigm, doesn't apply to this guy. Desmosomal mutations, 15% of transplant populations with DCM. This is the 71-year-old tennis player. Now, he had some scar. He's got scar subepicardially. Runs into the septum, becomes more mid-wall. What's that all about? Why does he have a scar? His nephew died suddenly. He's got a niece with a DCM defibrillator. What is the phenotype? What is the diagnosis? Well, what he has is a recently described gene called filamin, maybe about 5% of DCM. He leaves, he has a syncopal episode, pre-syncopal episode. Someone sees a 3-second pause on a tape, puts in a pacemaker, he dies 3 months later. What's the diagnosis? Did he die from his disease? Just because he's 71 doesn't mean he can't die from a genetic disease. Filamin kills you. Case 3, the young guy. He's got a twitchy heart. Why does he have a twitchy heart? From the atrium and the ventricle. Why? Because he's got an SCM5A mutation. That causes a twitchy heart from atrium and ventricle. This particular mutation is being described repeatedly, has a very particular biology, increases, it's a gain of function of the sodium current, which you can block. I know it's old, I know it's old-fashioned, I know it causes side effects. But the ectopy disappears. He's now got 33 ectopics. And the ventricle, not sure, this is not a great picture, but now his ventricle is 62%. So what am I saying? What I'm trying to say is that if we just define diseases by a single number, cholesterol, a blood sugar, an ejection fraction, we're missing a trick. Because they are traits, they're phenotypes, they're not etiologies, they're not diagnoses in their own right. And in the heart failure world, in the dilated cardiomyopathy world, we're starting to see the breakup of this entity, which maybe is a third of heart failure, into different types of disease. Titin mutations, about 25%. They get atrial fibrillation, they respond really well to drugs, they remodel really well. Lamin, AF, AV block with normal ejection fraction, and you drop dead suddenly. Filamin, it doesn't matter whether your ejection fraction is 40% or 45%, as soon as it's abnormal, you're prone to dropping dead suddenly. Whereas other genes, it's all about heart failure and not sudden death. So my take-home message is, we are physicians. I'm speaking to the cardiologists in the audience now. We've forgotten that. We've become technicians. Rather than listening and looking at the patient, we're looking at the end of the bed there to the guidelines. Maybe a little less about the guidelines. And I'm not saying guidelines are a bad thing. Guidelines are a great thing. They set the bar higher. They set a standard. But it's actually about making a clinical diagnosis. You can call it personalized medicine if you want to, but it's just about a diagnosis. A lot of the work I've shown you is, this represents global consortia in all continents. I'd like to thank them, and I'd like to thank the team at Barts for having to listen to this talk every week in clinic. Thank you very much indeed.